We're going to go ahead and get started. Welcome to the Chicago Forum for Justice and Health Policy, State and Local Perspectives on Lessons from COVID-19. My name is Wesley Epplin. I'm the Policy Director at Health and Medicine Policy Research Group. I'd like to do a land acknowledgement. Health and Medicine recognizes and acknowledges that we live and work in the land of the Peoria, Miami, Kickapoo, and Potawatomi nations. These lands were the traditional territory of these Native nations prior to their forced removal. They continue to carry the stories of their struggles for survival and identity today on these and other lands. As an organization located in Chicago within the state of Illinois, we are obligated to hold these histories and contemporary struggles in our mind today as we talk about community, belonging, and health. I have a few housekeeping notes. This forum is being recorded and will be available afterward on Health and Medicine's YouTube channel within the next week. A link to the recording will also be emailed to all registrants, so you'll be receiving that. Please place any questions throughout the event in the Q&A section, and please don't put those in the chat. And you can chat and comment in the chat, but for managing Q&A, we'd like those, if you have something to put that you would like us to consider for asking the panelists, please put that in the Q&A box. And we'll get to as many of those as possible during the last portion of the event. We also have closed captioning enabled for the forum. You can turn this on by clicking on the CC at the bottom of your Zoom window and selecting either live captioning or the view full transcript option. Also, if you'd like a copy of the transcript for your own use, we'll plan to close out the forum at about 5:30 p.m. So please try to make sure to do that before we close out. So who's in the room? We have a great number of people, and we'd like you to spend maybe a minute just introducing yourself in the chat. You can share your name, gender pronouns, title, and organization if you have one that you'd like to share. I know a few of you have already started to do that. Please continue to do that. It's nice to see people who are know who's participating in the webinar. So appreciate you taking a moment to share with the group. Wait just a minute for that. Okay. A little bit about Health and Medicine Policy Research Group. Health and Medicine's mission is to promote the health of all Illinoisans by advancing health equity. You can follow us on social media, on Facebook, Twitter, and LinkedIn at the links on the slide. Also, we're celebrating 40 years this year, and our gala is coming up next Thursday, September 30th. We hope you can join us. It'll be both online stream, but also in person. And we'd love to have you join us to celebrate. We have several wonderful award recipients who we'll be honoring as well. It's going to be a great event. We hope you'll join us. So today's forum is the third in a series of forums, really looking at lessons from COVID-19. So on July 29th, we had an international perspective. On August 26th, a national perspective. And both of those are available at Health and Medicine's YouTube channel. You can also access that on our events page on our website. Obviously today is the state and local perspective. And so I'll read through our speakers and then I'll turn it over. So we have with us today, Dr. Rachel Rubin, who's the co-lead of the Cook County Department of Public Health. Dr. Kiran Joshi, co-lead of the Cook County Department of Public Health. Dr. Allison Arwady, the Commissioner of the Chicago Department of Public Health. Amy Lulich, Senior Policy Advisor at the Illinois Department on Aging, and Dr. Evan Lyon, the Illinois Director at Partners in Health. For our moderator, we have Dr. Rae Murray, Health and Medicine Board Member and former President of the American Public Health Association. With that, I'm going to turn it over to Dr. Murray.
Well, good afternoon, everyone. I want to welcome you to this third in our series of webinars. I just want to say I've been looking forward to this particular topic more than the other two. As Wesley said, the first webinar, we had Matt Cavendish talking to us about international issues that we face because of this pandemic, a really nice conversation back and forth. I invite you to go look at the tapes. And then the last series was with Jose Ramon Fernandez Pena, our present APHA president, where we really concentrated on lessons that we should have learned from the HIV epidemic and what our challenges are nationally. But just like all politics is local, in many ways, all public health takes place on the ground locally. And I'm so glad we have an array of local leaders and activists here today. So I'm glad to hear that. We really need to ask ourselves, because even though the title says lessons learned, we're still in the middle of this battle. It's not over yet, as I'm sure most people here know. And I'm going to ask us as we go forward, and I'm going to let each of the panelists have some opening remarks, to suggest that this is a family conversation. We need to discuss, our participants, the ones who are signed in, the people we know who signed up for this webinar, are really public health people, whether they work specifically in governmental public health or other non-governmental organizations, or whether they work in other areas of healthcare and social service organizations. So this is like a family conversation. And what I'm really interested in us digging into is, what do we do going forward? Because we're not out of this yet. And what do we do today to prepare for our next pandemic, of which we know we're going to have one, and other problems and issues that face us in public health? So let me start. I'm just going to arbitrarily start with the list that I have written down. I'm going to start with our friend from Aging, Amy Lulich, to ask her if she has any opening remarks or questions. And I want to invite all the panelists to ask each other questions that you want to kick us off with before we start our conversation. Amy?
Well, thanks, Dr. Murray, and thanks to Health and Medicine for having me speak on this panel today on behalf of the Illinois Department on Aging and Director Paula Basta. I have to admit, I'm glad that I'm going first in a fellow panel, as the rest of the panel all have MD after their name, which I do not. So I will say I was a little intimidated by that, but nevertheless, I did want to share. I think that a lot of them will say this as well, or agree with me from the Department of Aging perspective. When the pandemic started, I was about a month into my job at the Illinois Department on Aging, and it feels like we have been flying the plane and building it at the same time. And I think that most people would agree with that, as we've been going through COVID for the past, over a year and a half now. For the Department on Aging and the Aging Network, we had to pivot very quickly from a system of delivering services to older adults in homes and communities to a system of, which was largely in person, congregate programs and services to one that was fully remote. All of our in-person programming was virtually shut down. And we are so fortunate to have an aging network in Illinois across the state that really showed resiliency and flexibility to pivot to provide services in a remote way, home delivered meals, et cetera. And our main goal throughout the COVID pandemic has really been to help maintain the health and safety of older adults, and in particular, maintain their ability to remain in their homes in the community. And so as we've been reflecting around the lessons learned and, what we might be doing differently, or what we might improve upon, in future pandemics or crises, I think that the number one thing that came to my mind when I was reflecting on the prompt was emergency preparedness. And, aging providers have been required to have emergency preparedness plans for natural disasters and other events as part of their operational capacity for years. But we had these new vocabulary in our system about PPE and, and IEMA and FEMA. And, I think that one of the biggest things is that has come from this is that from an aging perspective, we started to partner with agencies like IEMA and FEMA that we had never really partnered before. And our aging providers did that. And we distributed, over $24 million in PPE offset payments. So that allowed our providers to buy those gloves and cleaning supplies. Of course, they had things like that, but they didn't have that in bulk and at the capacity that they needed to be able to stay open and provide services in person in people's homes. I think, our in-home providers that are providing in-home services to those older adults and persons with disabilities, they didn't have the masks and the gloves and the, all those things that we, Clorox wipes to wipe, things down all the time. So I think the lesson learned there is that we hope to be able to have and make sure that our providers have that PPE and stocked and ready to go for future pandemics and crises. I mentioned at the offset too, one of the other things, the main themes that has resulted is flexibility. And we had a lot of service providers, things, services and types of things that were previously unable to be implemented or thought of as nearly impossible, ended up being crucial in order to keep people in their homes and communities. So one of the things I think that was most impactful, which we called emergency senior services, these were gap filling services that allowed our service providers to pay for things like ramps, home modifications, groceries, personal care products, utility payments. And these were things that, weren't in our kind of service delivery and our Medicaid home and community-based services program in the past. And I think going forward, we're looking at that and we spent over $2.2 million and served over 4,000 older adults in 18 months with these gap filling services. And we're hoping, to be able to expand that and take those outcomes and that impact and expand that into the future, not only for our program on a regular basis, but obviously to be able to utilize that in future pandemics and crises. The other thing I think that we learned and that we think that, we want to make sure that we're expanding and in the future to prepare is we all know the technological divide. It does exist in Illinois, not just in, rural areas, but also in urban areas in our larger cities. And, this made it this really highlighted the silent kind of disease of the pandemic, especially for older adults in terms of social isolation. And so we want to be able to continue our commitment as a state agency to the state's Connect Illinois broadband strategy to have basic broadband access in every home by 2024. And from the aging perspective, what we were able to do and what we're going to continue investing in the future is providing assistive technology devices like iPads, tablets, and Wi-Fi to older adults. We provided over 3,000 of those to older adults and persons with disabilities from 2020 to 2021. And we're going to continue to invest in that with state funding in the next year and also utilize federal funding to do that in these future years. And I think one of the other things that came to mind when we were facing this technological divide, not only to combat social isolation, but at the beginning of the pandemic, I think everyone remembers, I'm sure, that when appointments for vaccines first came out, it was kind of this flurry, and there were all these different platforms and websites and places you were supposed to go, and that was confusing for older adults. Fortunately, we were able to push out funding from the federal government to have our providers assist older adults, but with making appointments. But I think a multifaceted approach or a multi-pronged approach, both like phone, online, walk-up, et cetera, should be contemplated in the future. And so to kind of bridge that kind of technological divide, I think that existed and I think sometimes continues to exist, and something that we need to look at when we're talking about, booster shots. I know the word isn't completely done and decided with booster shots, but it's, it is looking like there will be some for those older adults, 60 or 65 and older. And somebody will clarify that for me, but we know a lot of older adults will be receiving these, as some already are who are immunocompromised, and we want to make it as easy as possible in terms of access. And so I think, the lessons that we've learned over the past year and a half, we're really fortunate because oftentimes the things that we learn and that we want to fund and that we want to develop, often, we're kind of handcuffed because we don't have enough funding. Fortunately, the federal government has been pushing out quite a bit of money in the American Rescue Plan and the CARES Act, and the department is, going to be the recipient, not just us, but we're pushing that money out to our providers around $150 million over the next 3 years or so. So we're excited to be able to take some of these lessons that we've learned and improve on what we kind of threw together during the pandemic. And then we also have included these strategies in our newly approved state plan on aging for 2022 to 2024. So it's our hope that this investment of funding and putting these lessons learned into work and this commitment to flexibility and connectivity will better prepare us in the aging network to respond to future pandemics or crises.
Linda, you're muted.
Thank you. You think after a year and a half of Zoom, I would know better, right? I was thanking Amy for really giving us a nice overview of what we're really talking about, real life issues on the ground and real life lessons to learn. The Department of Aging is looking at one of our most vulnerable sections of the population. Let me now turn to Evan Lyon and ask him from his point of view as Partners in Health, what should we be doing? What did we learn? What do we have to do in the next few months and years? And you're on mute, Evan.
Me too, a year and a half of this. Thanks, everybody. I'm really pleased to be here with leaders from the public sector and from health medicine policy research and others. Just quickly to orient, I want to introduce Partners in Health because we're new to working here. Partners in Health is about a 35-year-old organization that's worked primarily outside the United States on healthcare delivery, support and change for systems, education, capacity building, community health work. I worked with Partners in Health for about 15 years, back and forth to Haiti before coming to Chicago in 2010. Domestically, there was a small footprint for Partners in Health, but the pandemic changed that dramatically. In April of 2020, the governor of Massachusetts asked the organization if we could set up a contact tracing system for the state. And provided funding to do it. So that quickly came together. May 2020, Governor Pritzker asked if we could come and help in the scale up of contact tracing here in the state, and we were very proud to do that. We were also really privileged to work alongside and to accompany this similar process with Cook County Department of Public Health around contact tracing and that expansion to care resource coordination, understanding that being in touch with people in the pandemic, supporting isolation and quarantine with things, money, food, support for navigating a health system was going to be important early on. And then for the last year or so, we've been working really substantially in the Chicagoland area. We were invited by the Health First Collaborative, really hubbed inside of Michael Reese Health Trust, to take on a thing that was growing with early leadership from Health First and UIC, Public Health and Science, called the Vaccine Corps Partnership. And since January this year, that's kind of been our convening body where we're bringing community folks, organizations or individuals, public health and the healthcare system to be constantly iterating and looking for solutions to especially vaccine understanding and acceptance. And that's put us in a place where we can now think about your question, Dr. Murray. I think the biggest lesson, a couple of things, there's very little or no knowledge gap around, say, this pandemic. People understand quite well what's going on, the various dynamics around the vaccination and even the illness. But there's a massive gap in trust of health systems, of health providers, the health care establishments, public health, which may have been fairly invisible to people, is now visible, but we're facing a huge gap in ability to communicate and in trust. And especially for historically oppressed and marginalized people, it makes great sense that we've been neglecting communities for decades and now show up with a shot, and we should not be expected to be received with open arms. So we need to earn some trust potentially. Our singular approach has been to try and find ways for people who live in places that need more support to do that work. And so whether it's through outreach and training up for that outreach, providing support for community-based organizations, and local philanthropy has been incredibly generous to find new partners and expand the base of people who are participating in public health response and community health response. And to me, the key question I want to put on the table for today is, how do we hold on to and expand that capacity? This pandemic has shown us there's this incredible gap between what we know works from a public health or clinical perspective and actually getting it to people, having it received and understood and accepted. Great strides have been made to support initiatives. The Racial Equity Rapid Response team from the mayor, the Protect Chicago Plus, and now the Healthy Chicago Equity Zone process, to me, feels like it's all built to try to sustain and hold that capacity. And I think remembering the heroic and often really voluntary and unrecognized work that people did to talk to neighbors, to talk to their block, to put information in the corner store, to leverage outreach that was doing one thing, housing rights work or violence prevention outreach, and became incredibly effective COVID public health messaging. I'd love to see that held on to and eventually become an integrated part of both informing public health and then also delivering to the level of people on a block or even a household level. So that seems like the greatest challenge and opportunity at the moment.
Thanks so much, Evan. So now I'm going to turn to our local public health officials and ask them again to summarize what their thinking is 18 months, 2 years into this. What should we be doing in the near future and the far future? Let me start with Allison, if I can. Dr. Arwady, as our local leader, what have you to say?
Yeah, thanks, Dr. Murray. Thanks, Health and Medicine Policy Research Group. And, this has already been interesting and obviously is going to continue to be an interesting conversation. There's so much that we could talk about. I thought I'd pick up on a couple of things that we already heard from Amy and Evan and just add a few of my own. First of all, I think the traditional emergency preparedness, honest to God, there is nobody that does this better in the country than the Chicago Department of Public Health when we think about things like stuff, when we think about things like traditional networks, right? And we had, I feel like, in the way that emergency preparedness has historically been funded, the kinds of things we receive money to do, thank goodness we were sitting here with millions of masks and millions of gloves and, ventilators on the shelf, and it maybe was not enough, but my goodness, compared to almost everywhere else across the country, that was really designed to be, you're only supposed to have to cover your jurisdiction for about the first 30 days. And then the idea is the strategic national stockpile comes in and we all know what happened there. But I will say, first of all, that Amy, I like that you sort of started with that, because I think that there's the traditional where people tend to think about stuff. And I think in this case in particular, the PPE, right, was such an acute need. And then there's sort of the vaccine. And my team and, I think the whole system, we're pretty good actually at thinking about that. It's just making sure that it's scaled and talking to each other. And that, like, just because Chicago has enough, we were not prepared for thinking about all of the non-traditional partners who would be looking for these materials, right? So the Department on Aging, for example, and we were really focused on sort of providing medical level PPE for medical systems and kept it at that medical grade. And then in that setting, there was that. But I want to complicate the conversation a little bit around emergency preparedness, because I think that actually there's a few places where we can grow here locally, and that might not be as obvious, but they're the biggest ones, I think, that the low-hanging fruit where we can work. So number one is all things data. And I don't actually mean just the ability to share data with the public, because I think we've gotten, as a public health system generally and as partners, pretty good at that. But things all the way up and down the chain, looking at the laws around data exchange and privacy, things like, we would like, for example, just universally, if there is data that by law must be reported to the Illinois Department of Public Health, for example, that it can be made available to the local health department with all of the appropriate protections around it. Because what happens right now is every time we're looking looking for a data set, there's a lot of lawyers involved and it takes a lot of months. And I think what we have seen with COVID is that we had to do things so quickly compared to what we normally do, right? Public health, historically, we put out an annual report. We're doing the surveillance, even monthly, historically has been fast from a data perspective. And the public, but also the decision makers, the stakeholders, the community groups, have come to expect, for COVID, actually daily data. And not that we can do daily data for everything, but I do think this idea of responsive data and what it means and getting out of our own way from a legal perspective while protecting privacy is a space that no one is going to care about except public health, but there's a lot of work to do. And one little finer point on that is that there were some things that we had been hoping to get done and had even raised. And you look at things like, for a number of years, we had put forward at the state level, we wanted to require that any provider who was vaccinating any kind of vaccine report that into the state registry, right? And it just never got done. It was never the priority, et cetera, et cetera. Here comes COVID and everybody is scrambling. We're hiring all these IT people and the state's going crazy and, trying to get all these people connected so we could get COVID vaccine done. And so when I think, it's just one example, but when I think about like our moment right now, it's the moment to say, where are these pain points that slow us down and that are in our control? Certainly there's funding issues. And Amy, like you said, this in a lot of ways, I think for us in public health has been like a deluge on parched earth, right? Where you think about the administrative preparedness that is needed. And that is a term we use a lot. Everything from how do we quickly hire? This is not something we historically do well and quickly. How do we quickly contract? How do we get funding out to small community-based organizations, which is always what public health has wanted to do, but we often are working in systems where it's the same system if you want to spend $1 billion on a highway as it is if you want to give $5,000 for a community walkability assessment. And so thinking about how to create, use this moment to say, where are some lessons learned from COVID to work on some of the behind the scenes things like administrative preparedness, data access, some of that tech and informatics thing, I think is going to be really, really important. And then using that emergency preparedness framework, I think helps perhaps have that conversation be bigger. And the last thing, just for time, is that the other thing in emergency preparedness is, we've always had a focus on, hard to reach populations, right? But what that looks like on paper versus what that looks like in practice, I think, this has been, I'm sure for everybody on this call, sort of lesson after lesson after lesson. And I do think there are a couple of bright spots. And Evan, to your point about the things we're wanting to kind of build and continue. Every decision we're making right now at the health department, every dollar we're spending is to say, how can we take this money that unfortunately is super tied to COVID? 75% of the Chicago Department of Public Health budget right now is COVID, meaning it is short-term, it is tied to a disease, Congress has appropriated like that. And it's, and often it'll say, it's not just COVID, it's like for COVID testing in this setting. And we're like, but right now we need vaccine. And so thinking broadly about flexibility sort of at all levels and recognizing that it is not a good mechanism to say when Ebola comes along, when H1N1 comes along, when Zika comes along, that this boom and bust that makes it very hard to build the infrastructure that we need. But there is that similar work, I think, at the local level. And so we're exploring some things like working with foundations, thinking about ways to make sure we keep the competitive processes we need to have as the city. And then the last is that we continue the work of letting communities lead. And Evan, to your point, this has been just all of Chicago has stepped up, right? In so many ways. And I think particularly early on, and with a big equity focus, I would say, but by and large, not by accident. But I think when like the contact tracing, for example, here in Chicago, we already had written a plan for how we wanted to eventually have a sort of healthy Chicago core, if and when we ever got money that would entail working with community-based organizations and building that up and have it be something we use to work on chronic disease. Well, here came COVID, and we were able to say, hey, federal government, like, here's what we want money for. And so when we got a lot of money for contact tracing here in Chicago, we did the RFP and then worked with the Chicago Cook Workforce Partnership to say, if we're hiring 600 people, we want them to be from the West and South sides, and we want them to be from the community-based organizations there, right? Because the CBOs are also going to have a lot of struggles and challenges during COVID. And it's an opportunity to kind of create some tables. So that workforce, I mean, as I think you all know, has been amazing, right? They started as contact tracing. They've done the Protect Chicago work, the vaccine ambassador work, the staffing the call center. And we have managed to sort of say, look, this is a thing. Let's talk 211, right? In this upcoming budget. Let's talk connecting people to services, hiring people from community, and then growing a table that we don't try to build at the time of the pandemic. And so emergency preparedness for me is about sustaining these tables, and not just in a voluntary way. We love when people volunteer, but like the Healthy Chicago Equity Zones, which I presume most people know, but we've divided the whole city into 6 zones. It was a competitive process. There's a lead in each organization. Half are healthcare, half are non-healthcare, housing development, et cetera. And then in turn, each of those leads is funding community-based organizations in every community. And they are starting with the vaccine work. It's a very concrete way to get people working. But we've already got $30 million in other grants that are coming to sustain this work and move it into the mental health and the violence prevention and the chronic disease and those other spaces. So preparedness for me is about, how do we take this moment of COVID, build our systems, do what we can do in the short term, advocate, at the high level for some of these funding things that are needed, and make sure that we keep the things that have gone relatively well here. And I would think, really giving voice and funding to community is at the heart of that.
Linda, Dr. Murray, you're muted again.
I say the best stuff when I'm muted, so y'all have to trust me.
We miss it.
I was thanking Allison for, again, structuring some of our discussion. To what extent has our approach, our traditional approach to emergency preparedness helped us and hurt us? How have we raised questions like data management in our local and state exchange of information? I'm glad you brought that up. We'll come back to those infrastructure issues. Dr. Rubin, what's going on in the rest of Cook County?
Yeah, I know I feel bad for Dr. Joshi because he'll be way at the end of the line, but I'm close to the end of the line, and for opening remarks. And the bad thing about that is that your colleagues have said all of the really sort of profound things. But the good thing is that I've been able to jot down, as we've been talking so far, about some additional things to build on with what has been said. So it might sound a bit like a mishmash, but the things that come to mind in terms of, we all, I think, at the table here will acknowledge that what we want to try to do is to leverage the unfortunate, tragic situation of COVID to building up public health and other infrastructures in order to continue this work in the future and to prepare for the next coronavirus or the next arbovirus pandemic, and to potentially put in place things that might prevent an epidemic becoming a pandemic. And so I think that that's sort of at the base, that everybody understands that we want to do that. But then how do we get there, and where are the gaps, things that we really have to focus on? And one thing that's come up is about the lack of trust in communities. Absolutely, we're still seeing that. And I think that all of us are chipping away at it. But it's really a slow process. And when I say slow, we think of slow as not in years, it's really in days, because we don't have time to wait we have to make transformative change happen now. It can't be something that we allow generations to take, but nonetheless, it still seems to be a slow process. And that means that we build into whatever we do, thinking about those questions about trust and about equity and about inequities that are existing in our communities, and where the underserved and most under-resourced communities are the hardest hit by the pandemic. And as much as we're trying to focus on those communities right now, it still feels in some ways like putting a Band-Aid on it. Bringing a vaccine in some ways feels like a Band-Aid. We're doing whatever we can now to provide transportation, so that, including paratransit, so people can get to vaccination sites, or setting up, expanding our in-home vaccination programs. But are these things going to be sustainable? We need to be providing economic development in our communities more so, not just giving lip service to it. Building up public transportation processes, making sure that if we're going to be in and out of pandemics potentially, or even this one for a while, to make sure that for educational opportunities that everybody has, all of our children have that opportunity, not just those that have a strong enough internet, not those that can't afford childcare, so you have older children taking care of younger children because parents have to go out and work. And so we have to be addressing these issues now, and they have to be sustainable beyond the ARPA funding, beyond the grants that are coming down the line. So another thing that this brings me to is also how things have been funded. It's been sort of on these grants. And as Dr. Arwady talked about, and Amy Lulich also talked about, is that, these things are the grants are set up for very specific purposes. And even within COVID, even very small projects. This one can only be for contact tracing. You can't use your contact tracing staff to do community engagement, though we are, okay, right? So to allow flexibility, to allow breaking down silos with even our own departments and between our agencies so that we can work. And those funding issues, like Chicago is really lucky, you get direct money from the CDC. Our money goes through the state. The CDC money gets channeled through the state takes their cut, and then they give ours. And then the state puts added controls on the dollars that we get. Also, where there isn't this information sharing that several people have brought up so far, in that and every state is different, and the federal government doesn't have a national registry for vaccination. EMRs, electronic medical records, do not talk to each other. When we have an outbreak in suburban Cook, let's say it's a measles outbreak, we can get on the phone. I mean, I can pick up the phone and call Allison and say, are you seeing measles? Let's share our data. But we have to sort of do it as around the end. We can't go to the state. Now the state is getting better about it. I don't want to trash the state. But the state is set up in a way where there are these firewall walls between jurisdictions. So we can't share and see each other's data unless there's a special request and we justify it. To me, that seems ridiculous. We're all public health professionals and we all know about privacy. We all know how to contain this as best we can. So those things I think need to be dealt with. And then sustaining the resources that we have been putting in play, like the personal protective equipment, like the vaccines. Vaccines need to remain free. Right now, private business is getting into the testing business big time. You can go and buy an off-the-shelf product in the Walgreens or CVS and it costs $25 or $50 a pop. That's not affordable. I was reading an article yesterday, or hearing a report about in Europe, where testing is extremely widely available. And a lot of it is maybe home kits, but they are subsidized and they cost almost nothing. They're either free or very highly subsidized so that people can do serial testing. So even if they're doing the antigen testing and not the PCR, which is supposed to be better and all of that, if you do a lot of antigen testing and you do sort of serial testing, it's better. It works better. We don't have to talk about the science behind that and the epidemiology, but the idea being that, if I can test myself 5 times a day, maybe the first time it was going to be negative because it isn't that accurate of a test. But if it tests positive that 3rd time, I better trust that it's positive. And so the idea that these resources are available and that they're free and they continue to be free, that we don't start out by allowing these resources to be spread around, and where we can distribute vaccine, we can set up vaccination clinics, where we can give out personal protective equipment, we can provide free transportation, but then that only lasts for a certain period of time, and then people are going to have to start paying for it, and then that's going to exacerbate the inequities that we already have been seeing stretched far and wide. Let me see what else is. I think, you know what, I'm going to leave it at that. I think that's, one final thing, because this is my little crib sheet here, is that's also been brought up, is that one thing that we have always struggled with in suburban Cook County, because we're so vast and have to deal with so many different municipalities, And we don't have the same level of community-based organizations and structures as the city does, is that we've been able to leverage those. And we've developed tremendous relationships. We have strengthened the relationships with organizations that traditionally we have worked with, and we have developed new relationships, and they have helped us understand better ways of engaging with our communities. So if there can be some way of continuing those kinds of relationships above and beyond COVID, but in a way that is also sustaining, that is sustaining in terms of dollars, that is sustaining in terms of energy and human power to do that.
Thank you, Dr. Rubin. That wasn't a mishmash. That was a laundry list of things we need to get done. Dr. Joshi, what have you to say?
Thank you so much, Linda. Thank you, HM Health and Medicine, for the invitation to speak. Actually, I don't mind going towards the end here because I have the unique opportunity now to underscore and maybe synthesize a little bit some of the critical things that I heard. It's a little difficult to believe that it's been almost 2 years since we got the call, since actually I got the call from Rachel that we had our first case of COVID up in the northwest suburbs. So I think somebody made a comment about just the idea of building it while we're flying. I think that's certainly been the case. Dr. Murray, I know how much you love reading business books and love military acronyms, so I'd be remiss if I didn't drop one here. And so if anybody has heard of the concept VUCA, I think that very much applies. VUCA stands for volatile, uncertain, complex, and ambiguous. And as soon as I heard that term, I thought to myself, oh my goodness, that is my job. And at this point, I think it should really be written into the job description of everyone that's working in public health, because I think to some of the discussions that we had prior to this call to discuss the substance, this is a time of great uncertainty with a lot of significant public health threats that are going to be coming our way. I think I'm really proud of all the great work that we've done under challenging circumstances. And by that, I mean, to be clear, it's not so much me and Rachel, but the amazing work that our staff at CCDPH have done under some pretty difficult circumstances. The main issue is that we were really not prepared. And I don't think that's really a controversial thing to say. I think it's well documented that at local, state, national, and really global levels, we were not ready for this. I think there are many factors that played into it, some of which Allison alluded to, relating to structural issues, funding, siloed funding, of course, system issues, including data issues. And to your question, Linda, to your framing question about emergency preparedness, I think part of that was that there was this post 9/11 emphasis on bioterrorism. So for 20 years now, we've been fighting that last battle. And I think that mindset certainly needs to shift at this point. Because I always felt that as we were going forward in our response, we were trying to be as thoughtful and intentional as possible about addressing, about keeping equity in mind with all of our efforts. But by the time we had solved one problem, by the time our plans were ready to be implemented, things had changed. The reality on the ground had changed. And so then it was always very challenging, and it remains challenging for us to pivot. It's difficult for all government entities to pivot quickly due to, I think, these constraints that we have on hiring and purchasing, many of which are, perfectly well-intentioned and intended to prevent problems, but in the setting of an emergency, I think really need to become more flexible and more agile. One example of this is, as per Allison's comments, trying to fund really small organizations who have really small budgets and aren't really able to float costs for months on end. We need to find ways for these organizations to be paid in a timely fashion. This is a sort of a boring administrative issue on one hand, but really is an equity issue on the other. So I think in sum, I'd say it's really critical for us as public health to lead and to do so with social justice and with health equity in mind. But it means not only talking the talk in public and in professional settings such as this, but also remembering that there are these system and administrative issues that we really need to address as well if we're truly to advance health equity in an effective way. Thanks.
Thank you. So let me, as the oldest person on this panel, let me try to give some historical perspective. And I'd like our discussion to float around three broad areas, which have all been talked about. They can go beyond that. And let me just say right now, we're not going to do a round robin, jump in, ask each other questions. But let me just remind people, it's not really, let me just point out that during the Black Plague in the Middle Ages, the years of that repeated plague shook the foundations of the feudal system and really made it possible for serfs, people tied to the land, to change their status a lot and improve a number of their rights and ability to survive. So pandemics do present a unique opportunity. And as someone, we're talking about this pandemic as though, and I know people on this panel know this, it's not our first pandemic, obviously, certainly in our careers, but I'll just point out that when I was at the Chicago Department of Health in charge of HIV, among other things, and general communicable diseases, that we had beautiful new computers, which were new to the concept of government at that point in time. And we were not allowed to use those computers on anything except HIV. We couldn't use them to track measles or mumps or syphilis or any of our other reportable diseases. And this is in my lifetime. So a lot of these problems we're talking about in public health, we know that they've been problems. We've been fighting about them for years. And so that's one area that I want to look at. I'll come back with a specific question in a second. What things do we know we should be doing in public health that we haven't done? Not because people are evil or lazy, but just because it's frustrating and we haven't gotten it together. Then, of course, there's the deeper issues. So that's sort of a leadership question. Then there's another issue of how do we construct an infrastructure? We don't often get the money that we presently have. We've already talked about some of the problems with that, but where should we start with the infrastructure? Too often we're sort of in competition. Should we do smoking cessation? Should we do HIV prevention? Should we do, well baby care? What should we do? And last, which is what I'm really concerned about, it's not just a question of lack of trustworthiness, which is a perfectly natural thing if you consider the US government. I was on the phone recently with Michael Bird, one of our past presidents of APHA, a Native American, who said, who should have more lack of trust than Native Americans? So it's not just a question of a lack of trustiness, it's how do we communicate uncertainty? How do we take science from being a quasi-religion? The science told us to do it. That always makes me on edge. And how do we have lay people comfortable with the concept of uncertainty and how we actually develop our questions? But let me go back to a leadership challenge for us in public health. So everybody on this call has mentioned either here or in other places how critically important racism, structural racism, wealth inequity, how critically important these structural determinants of health are. But so often we can't find a way to speak out in our role as public health. I was commenting that recently in the Annals of Internal Medicine, there was a great article coming out of Drexel School of Public Health that's looking at some of the spatial and geographical problems we have. And I know the city and I think the county too have produced maps that show these vulnerability in indices. And so one of the issues that's been in the paper recently has been our environmental indices and our environmental problems, both the general iron issue that challenges the city. A few years ago, it was the Crestwood water issue in suburban Cook, where we just allowed poisoned water to go around for 2 or 3 decades. Our whole region has a challenge with lead service pipes and probably one of the worst situations in the country for that. So how do we find a way in our role, both as governmental public health, as non-governmental activists and members of other organizations, to really make clear to people, make visible to people, the standards for social justice that public health so desperately believes in? How do we find a way to have a better chance of doing that? Anyone jump in, unmute yourself and jump in. If you don't, I'll call on you, but you can certainly jump in. Anyone want to start there?
I'll
Evan,
maybe just
Oh, go ahead. Go ahead.
Allison, if that's okay. Yeah, I think we need to begin by actually having the conversation about it. And I think over the last few years, it's become, I'm not going to say easier, but it's become less difficult. I mean, I think back to, I think perhaps 4 years ago when I was having a conversation with a medical student or a resident actually who wasn't sure if it was appropriate to talk about structural racism in a professional environment. I think in a post-George Floyd world, that has changed dramatically. So I think that's a good thing, and I hope it continues. Our agency has been, I think, pretty explicit in calling out structural racism as a driver of health inequities, and we try to weave that into our communications at every opportunity we get. It's not easy, particularly given our country's sort of historical focus and culture around, the rugged individual, but I think we're all here kind of in this to fight the good fight.
Allison, were you going to jump in there?
Yeah, I would maybe just to add to that a little bit. I think, everybody probably on the call is familiar with Healthy Chicago 2025, which has as its focus the racial life expectancy gap in Chicago. And then we have quite explicitly said, those 5 main drivers are the proximal things that we're following, but then what are the root causes underneath that? And to bring it back around to some of this environment conversation, for example, I think so often where these things really jump out in our face in a geographic way, which happens a whole lot in Chicago and suburban Cook, right? We are a racially, ethnically, economically, linguistically, highly segregated city, which everybody knows. And so we sort of have this interesting shorthand for kind of place and race here, which was so strange when I moved to Chicago to kind of get my head around. And I think what's interesting is it, on the one hand, it offers you an opportunity to invest in place-based approaches and really think about when we're wanting to example, we'll see what happens with this budget, but there's $1 zillion in there for, trees and working on investments in clean air and all the rest of this. What is the data that you're using? Where does that go? How does it play in? But that's sort of fixing, if you will, problems that have been very, very longstanding potentially in terms of who gets to make decisions and whose voices are heard there. So I would also just say that kind of in the same way, like there's always this sort of not quite as sexy behind the scenes work that needs doing, as folks who work in policy well know. And in this space, for example, some of the work with some of the issues for some of the things that have come to so much attention in the environment space in Chicago are because literally there has never been any opportunity to do a health impact assessment or a race equity assessment, right? And we're trying to think of these sort of health and race equity assessments together, et cetera. Those have never been done before zoning decisions are made, for example, right? Historically in the city. And we think that is a problem. And so some of the work to sort of, even this last summer to say, let's actually say when particular developments are ticking boxes, public health gets to take a look. Public health gets to require that if you're going to put something near a school, that it shouldn't just be an automatic look. And so trying to get ahead of some of these situations and actually build it into our policies and kind of our structures, I think gives you the opportunity to take some of that data, which you're right. I mean, everybody knows what these maps of Chicago look like, and you can overlay the vaccine uptake to you name the issue, they look the same. But being serious about addressing that in a locally based way often means sort of, I think, going kind of upstream to where are some of these policy things that we can do to think about cumulative impact, to think about things that do not exist right now in our city code, in our laws, and really take these individual examples and make it a larger conversation about what we need to do for more equity in public health and environment, which is we name it as one of the primary root causes is Healthy Chicago 2025.
Yeah, and I think this notion of health in all policies, from the Department of Transportation on down to the Department of Revenue, at whatever level of government you talk about, is something that I know that has been talked about for a long time, and and I'll just add, and I know that this is something that Health and Medicine is interested in too, is, you know, I'm going to add another aging in all policies type of perspective as well, because I'm representing, you know, the Department on Aging. And I think that, you know, one thing our director says all the time is that everyone's aging. And, you know, we just finished our state plan, like I mentioned, and we have, you know, some interesting data in there. We're going to hopefully update it as soon as we get kind of in all the census data and kind of distill through that. You know, the population is getting older. We are really approaching that 30%. I think it's like 30% of the Illinois population by 2030 is going to be over the age of 80. And so, you know, it's getting older, and you know, we want to make sure that not only we're thinking from an equity lens, but equity lens in all policies, but also how are we making these policies for older adults, so that not only the Department on Aging or the, you know, Division on Aging is thinking about older adults, but everyone's kind of thinking with that mindset as well. So I just kind of add that on to, as we're thinking about how, you know, the Department of Transportation is making sure that sidewalks are safe. You know, not only are they safe for, you know, able-bodied folks, but also for those who aren't as able-bodied.
I want to add a little something and connect back to one of your other big questions, Dr. Murray. You know, public health has always known that basic necessities create, you know, lack of basic necessities create health inequity, housing, nutrition, education, gender difference, racism, et cetera. And I do think people have seen that a little better in this current moment. And so holding on to understanding that it's a cause and not just some loose correlation. I think healthcare is catching up, like you mentioned, Dr. Joshi, to at least use the words about social determination. It's rare that a nurse or doctor is actually working on a solution to housing instability, but I think that is part of our future. In support of, you know, understanding where these problems are and having them be, you know, this question of how do you build infrastructure. The regional approach of the Healthy Chicago Equity Zone stuff is very exciting, because at least some decision-making will be brought down to a regional level. And as we finally get to work less on COVID, neighborhoods, regions will start to discern for themselves what health prioritization will be. And in one place it will be mental health, and another, you know, cardiometabolic disease, et cetera, et cetera. And I think another way to extend that to its real logical endpoint is to have people who work in public health who can both serve in the process of navigation and education and outreach and breaking isolation, that kind of community role, but also represent what they see at a seat with public health. So to be both serving, but also representing as community people. As you notice that, say, one entity is not working well, then advocacy can grow to, you know, kind of increase that. So I think the infrastructure that'll spread some decision-making, but hopefully down to the level of a person who knows what, you know, Ms. Jones has suffered to try to get her heart failure cared for in Roseland, will give us a depth of understanding about where the structural barriers are, so we have a chance to address them at that really intimate level. It's exciting to think of the larger investments at a city level in safety and parks and those things, but I think connecting to this very intimate person-to-person level will be important for staying with the right priorities and with the right policy.
So this allows us to think also about how we do that infrastructure. So for example, if we look at environmental racism, we have islands that are communities in Chicago that are really overburdened. Pilsen Little Village being one, but probably the biggest in our region historically is really what we call the Southland. That is the southern part of the city moving south into the rest of Illinois and into Indiana, with huge legacy industries like the steel mills, refineries, some of which are still in operation. So when we talk about environmental racism, when we talk about wealth inequities, it seems like we have to start there. And so one of the things that I think might help us is to be able to share some of that data on a local piecemeal basis, not wait for the state to figure out how to do it appropriately. So that if we look at, and I'm really concerned as we start measuring these inequities, because these populations have changed. It's been 30 years. Black people have been moving. They've always been in the Southland, but the egress out of the city has been great. How can we talk about Pilsen Little Village without talking about Cicero and Berwyn and Summit, et cetera? So to me, one of the things that on this panel you might have an opportunity to do is to begin to piece together some joint approaches that put data together, ignoring those political boundaries, at least to state clearly to the general public and to our political structure, here are the real issues we're facing. And here's how they've changed in the past 25, 30 years. So in that spirit, and I don't, by the way, Allison, I don't think these are, well, they might be boring or irritating, but I don't think they're unimportant. And I know you don't think so either. Bureaucratic challenges, these are real challenges. You know, you have to be able to hire people quickly. You have to be able to pivot. You have to be able to fund. If you're not going to fund a small community organization and you expect them to spend the money before you reimburse them, then you're not serious about, you know, having that work done. So it means really fighting to change the rules of how we hire people, how we disperse money, and how we present our reports. And they can be changed. So
just maybe one thing, if it's okay, I could say is that I wanted to lift up maybe an under the radar collaboration between ourselves and the City of Chicago's Department of Public Health, and that's around the opioid space. So the death data for opioid overdoses resides with a Cook County Medical Examiner's Office, right, which has a jurisdiction of all of Cook County. And so we actually have a really nice series of meetings with our colleagues from the city in which we review all the deaths in Cook County jointly and, you know, sort of confirm the ascribed cause of death. And from that comes a joint report. And I mean, again, I think this is small, but it's a really nice example of good collaboration. And we'd certainly want to see something like that grow and expand.
You know, and one thing to talk even further, I mean, in some ways, I'm not quite sure what the solution is. But in the suburban area, it's one thing between health departments. You know, we can continue to build and expand our relationships with Chicago Department of Public Health, the other certified health departments within the suburban area, you know, the other collar counties, because we all know each other. I think we generally like each other. We understand where we want to go, I think. But when we're talking about government structures, like in suburban Cook alone, there's over 130 different municipalities. And so we have to deal with all of these separate different governmental structures. And some are towns, some are villages, some are cities, and they all have some have city councils, some have village boards. They're all very different. And then there's the whole home rule, where there's certain things that we don't even have jurisdiction of in the health department. It's only unincorporated Cook County, where we can do food inspections. We do food inspections in other parts of the county because we're on contract with local municipalities that don't have the resources to do their restaurant inspections or their shopping center, their grocery store inspections, et cetera. So it gets not only complex, but it's a way that these different fiefdoms throughout the county can all compete for the same dollars and all compete for the same resources. And if there's a way of trying to break down those kinds of barriers, and I think one way of doing that is through engaging with community-based organizations and grassroots organizing and supporting those grassroots organizing, such as what we're trying to do with worker centers and working with worker centers that work throughout suburban Cook, and they also some work in the city as well, and having them work with us about education and outreach about workers' rights. And I want to begin to expand that, not only workers' rights under the responsibility of management to protect against COVID infection throughout a workplace, but all other health and safety issues, right? What does it mean for right to know? What does it mean in terms of trying to push for paid sick leave and paid vacation for all workers, whether they're part-time or full-time workers or temporary workers, so that they can go and get their vaccine, so that they can take their kids to school or to the doctor, right? That all of those kinds of things, and to try to deal maybe on a legislative level and get rid of this home rule opt-out. You can't opt out of minimum wage. I mean, in the state now is a minimum wage law, and that's one way of doing it. But to me, it's almost overwhelmingly complex. And I keep coming back to saying, I want to be out there on the streets, you know, with my sign, with my mask on, and saying that I'm here to support you in this environmental justice group to make the environment safe. I'm here with the worker centers, you know, and I'm trying to give whatever resources I can from the health department to do that. And then we use that from the grassroots to the grass tops to try to create real substantial policy change.
Many people argue that we make progress in public health only when we join forces with social movements, and certainly that's sort of my reading of history. I'm looking at the Q&A list, and we have lots of questions there. So I don't want to ignore our participants. Let me bring some of them. Some of them have to do around schools. What's going on with our K through 12 schools, how we're doing. As you know, Delta is hitting our younger population more than the original virus. And so there's a lot of concern first about CPS appropriately in terms of what they're doing for testing, but also in general, how are we approaching this problem? We have a patchwork across the country. This has been a controversial issue around the world, and different countries and regions of the world have had different approaches. But this may be a perfect example of a question that allows us to talk about uncertainty and how science develops. I think we have one pediatrician and a family practitioner on the call. I'm gonna start with you two, and us. Oh, Evan, you're an internist, right? Am I right? If my memory right?
That's right.
All right,
yeah.
so us internists are gonna keep our mouths shut for a minute. So let's go to Allison and Kiran.
Sure. Yeah, I did med peds, so I play both sides, depending a little bit what the rules. But yeah, so and I think this is a great example of this because it's an area that we knew very little about when COVID was starting, right? Like where you look at most viral illnesses, influenza, we would expect young children, like the oldest people, to get hit really hard. And we also, influenza has been our playbook in a lot of ways, where we are doing our emergency preparedness planning, and knew that schools for that can be a significant source of transmission. And, we had done calculations around rates and when we closed schools. And I think a lot of this just happened so quickly that, we ran through everything very fast. But what we learned over, by collecting data, including here in Chicago, was that with appropriate mitigations in place, we actually did not see schools being the driver of sort of COVID spread in the community that frankly we expected they would be. And I remember the beginning of last year, I was horrified to see these schools opening like across the South. I was like, what are they doing? Like this is gonna just light, the world's worst outbreak. And we really didn't see it. And it was this example of like, sometimes I think our prior biases can make us assume, nobody knows. So you always have to make your best guess based on the information you have now. But what was so interesting here was that, for example, through all last year, the Archdiocese of Chicago, which spans both Chicago and suburban Cook, it's the largest private school system in the country. And they were fully in person. And it gave us this sort of natural experiment between that school system that was in person, and then at least in Chicago, Chicago Public Schools, which for most of the year was not. And we're actually able to compare and say, it turns out that, in the Archdiocese, we were not seeing higher rates among students or staff, right, than what we were seeing in the comparison. And it was data like that emerging from around the country that made us say, you know what, like, it might surprise me that this is true, and yet not just here, but this is being replicated. And so it's one of the things that I think it's been challenging for me, because I think it's one of the things that I personally have been perhaps the most outspoken about from fairly early on around the need to sort of get back in school, et cetera. And then that's being balanced against risk. And people have, risk is such a hard thing to communicate. There is no such thing as a zero risk setting. Of course, the most the way to never have your child ever have an exposure to COVID is to keep them home forever. But where we balance sort of the risk benefit of COVID, and knowing that right now in Chicago, I've got one, less than one, significantly less than one Chicago child under 18 being hospitalized, across the entire of all of Chicago right now every day. Like it's the risk benefit there, where you think about the loss of not just the academics, but the social and the emotional and the supports and all the things that the roles play. It's been something we feel I felt strongly about, and needing to try to communicate, like, this is my opinion based on data, but we are still learning about this, and it's going to continue to evolve. And I cannot guarantee safety for your individual child, but I can say that statistically, right now, just to put a finer point on it, there have been about 500 cases, right, reported in Chicago public schools in these first few weeks. And that's really scary. That's scary for parents to hear. Oh my goodness, we've been back 500 weeks. But when you forget there are 300,000 plus, right, like folks who are there, it's not one, and these are the kids and the staff who may have been in school while they are infectious. So I get that's worrisome, but it's not 1 in 100, which is what people think it is. It's not 1 in 1,000. It's not even 1 in 10,000, where you're talking about how many that is, like, per day. It's about 5 or 6 right now per 100,000 cases that we're seeing. And so that risk, like, for me as a scientist or an epidemiologist, feels very manageable when we've seen such negative impacts and learning loss and all of the racial and ethnic disparities and socioeconomic disparities that have worsened. Like, we're going to be recovering from this with our kids for such a long time. But just because I can see that in the data, it is a very hard thing to communicate. And I understand people's concerns. And we say, here are the most important things from a public health standpoint: the masking, the testing, all of the work that's been done to improve the ventilation, et cetera, in those schools, and trust that those are the biggest things, and that these other things, as we layer them on, are on a system that we've shown can be safe even before vaccines were available. But it's been really polarizing, as you all know, who live here in Chicago. And I do think, thinking about ways to tell stories in different ways and recognize and hear people's worries, because they're very real, and everybody is trying to make the best decision for their families and their children, and feeling sort of the weight of also needing to make the decision of what I do think is best for, Chicago's children broadly, has been a real challenge for us, I think, on a communications front. It's also been one of the areas that's been most polarized or politicized in our Chicago conversation. We've managed to avoid that in a lot of ways here. I think where there are disagreements behind the scenes, we've generally, I think, done a very good job of saying, I don't want anything to get in the way of sort of that unified front in terms of talking about the importance of vaccines or pandemic approaches, et cetera. But I think just because it is such a polarized issue, we've felt that part here in Chicago more than some others.
Kiran, you are working in a setting where we have many, many more school districts, and I know you yourself have some school-age children. What have you seen in suburban Cook in terms of approaches to this issue?
Yeah, I just say 2 quick things, and then I'll turn it over to Rachel, because despite being an internist, which I don't hold against her, she's really been leading a lot of the conversations with the schools. And it's that when we first started having this conversation about closing schools, I was really, in the beginning, back in 2020, I was dead set against it because of equity. I was very concerned that the children that would be harmed the most, the families that would be affected the most, are families who were vulnerable and low income. Where were they to find the childcare? We don't have universal childcare in this country, right? So wanted to sort of mention that as an example of the structural barriers that we kind of started the conversation out with here. So let me just pause there, and actually I'll turn it over to Rachel, because I'm sure she has some things to add to the conversation.
Yeah, I think from what Allison was saying is that we also haven't found that the rise in cases have really been driven by schools, but by activities surrounding the schools and outside the schools. So the summer camps and the parties, the pool parties where it rains and then everybody crams inside and then 20 kids get sick at a school, a school age preteen party, whatever it was, and we see this. And with hockey, I wanted to strangle the skate rink, management, because he kept on seeing outbreaks in these hockey teams out in the suburbs. So this is where we were doing it. But the idea is that we're seeing more and more cases amongst the young because those are the people that are not vaccinated. And so that's where we're going to be seeing the cases. But all of these inequities do come in play in terms of not only inequities, but there are some children that just can't learn in front of a computer, even if they have all the bells and whistles, that it's not emotionally or physically, they are just not capable of learning in that way. So I think the idea of trying to be flexible, to allow hybrid to continue, especially to give comfort to parents that feel that they can handle that at home with their children. Also, certainly for accommodations for children, and we're trying to do that I know most of the suburban school districts are, and certainly the city, is that for children that it's not safe for them to be in schools because of underlying conditions, that they can study remotely, or if they are in quarantine or isolation related to COVID, that they can study remotely. But it's, I think what's more important, even at this point, is that I think it is safe to have children in school if the schools are all resourced appropriately. And that means, and we see this, because the suburban areas, as you see in the city, it ranges from the super well-equipped and well-endowed schools to those that have almost nothing. And in terms of being able to have robust testing programs in the schools, to be able to have the appropriate ventilation systems upgraded in the schools, to have the cleaning staff and supplies, to have the right processes put in place for movement of staff and children throughout the day, so that you don't have everybody out in the hallway at one time, in passing at one time, that you do have rotating throughout the lunchrooms and that kind of thing, which we know happens very well in some schools and not very well in others. And so I think we need to be giving not only appropriate guidance, but there needs to be the right kind of resources in schools for that to happen. And then I think it can be safe for children to be in school.
We only have a few minutes left, and we have a lot of questions in the chat. So let me try to summarize our final question and go around very carefully. There are several questions in the chat that are challenging us about what should be the role of the private sector versus public sector. And as we think about a lack of trust and political pushback, some of it is a lack of trust, some of it is just a disagreement with what governmental public health should be doing. I'd like, as a final question, to say, going forward 5-10 years, do you think the authority of governmental public health should be decreased? There's certainly a lot of pushback legally right now going on in the courts, suggesting that people don't have a right to do this kind of mandate, that kind of mandate. Or do you think, in fact, that the legal authority and the activity of governmental public health should be increased to allow us to better address these crises in the future? So I'm going to end up with governmental public health. Let me start again as I did before. So we only have a few minutes left. So just your opinions really quick. Let's start with you, Amy.
Well, I think in terms of the lack of trust and what we've been dealing with, and from an agency that serves folks, statewide, from the city of Chicago, Cook County, Central Illinois, and downstate, we've talked with a lot of our stakeholders and a lot of our aging network providers, and a lot of us tell us afterwards, what works in the city of Chicago doesn't necessarily work in Cairo, Illinois. And I'm sure a lot of you have seen the different articles, and we asked our providers to survey older adults when they would call them about helping them make vaccine appointments, and we got these anecdotal responses, and a lot of it in some of those southern Illinois counties and areas is, they don't trust government. There was a large, wide range of answers. They think the government is tracking them and all the things that we've heard. And so the thing that I think that, that from an aging network perspective, we've been, like I mentioned to you, as I mentioned in my opening remarks, is that we've started to really branch out to try to have some non-traditional partners. I think the aging network, sometimes we get so insular and we just are kind of in our own world dealing with our providers, across the range of services. But this was, for some of our aging network providers, our area agencies on aging, this was the first time they had reached out, for example, to their local public health department. And for someone who has worked in more traditional public health and now in more of the aging space, I wanted to shake people and say, please, even though some of your local public health departments are small, there may be one or two people just kind of checking off the boxes of doing life safety, health, sewer inspections. Like, please, please, please reach out to them, because they are a wonderful resource, not only to get something from them, but then to branch out with other organizations and other community organizations. So I would say, from an aging perspective, I hope that we will be able to work with our other non-governmental and governmental partners, both public, private, to really continue to share and learn from each other. That, I think that's one of the biggest takeaways that we've learned as a network, is that there's a lot of crossover in some of the services that we do, and we work better when we join forces and work as one together.
Great. Dr. Lyon, you work both out of the country and in the country as a non-governmental agency. What do you think should be the role of local health departments, state and local health departments, going forward in the future?
Yeah. I think the greatest opportunity is for public health to be influential across the spectrum of things that create wellness or create inequity. It's a great organizing tool, right? We mostly agree it's better to be healthy than sick. It's better to be alive than dead. And so for public health to be part of any conversation about, say, the criminal legal system and perpetual punishment, and approaching that as a consequence to someone's long-term health. The same for housing, the same for food, gender-based violence, et cetera. So to be really the central way of assessing whether things are working in public policy or not. And I just wanted to mention quickly this conversation and what you mentioned earlier, Dr. Murray, is around movements and where change can come from. It's making me think of the story I've always heard about Lyndon Johnson speaking with Martin Luther King about voting rights and saying, I'd like to pass it, but I don't have the votes. Please go get them. Please go get them for me. If we can build a more engaged, community capacity, especially if they can become these representatives to community in the public health system, and eyes and ears become legion, then there won't be a choice but to do better, because we're going to be, the hydraulic pressure will be really substantial, and that gives me a lot of hope.
Great, thank you. We'll come next to the county. We'll end up with the C. Rachel.
Yeah. Sure. I think the local public health should be seen as having not just building influence, but through policy to have more authority to protect the community's health. I think that we're stymied by political imperatives that have nothing to do with health. I think that we're stymied by this notion that individual rights can supplant, your neighbor's health. I don't think that that's what individual rights mean. I mean, okay, maybe I can decide not to be vaccinated, and then that means that I shouldn't be allowed to go into a restaurant, because I shouldn't be in a situation where then I can infect somebody else. So I think that, that's sort of on a micro level, but I think that public health should have better leeway and authority to protect the community. And I don't mean autonomously, but all of us, I think, around the table here will all say that everything is public health, right? So that means looking at making our communities safer in terms of pollution and making workplaces safer. I think all of these things sit within public health, and there need to be appropriate laws and regulations and statutes that allow us to enforce policies that maintain the health of populations.
Karen?
Yeah, so I'm going to answer the first part of your question about the strengthening or weakening of public health authority with a non-answer, which is that I think maybe we need to clarify what we already have. I think one of the major sort of not arguments, but discussions that was had over the last couple of years is like, what exactly is our authority? You know, what can we do? And so I think having some of those conversations now has been helpful and hopefully provided some degree of clarification going forward. I think probably we need to be a little bit more forward thinking and continue that. As to the question about our role, I think it's interesting because we need to be both the fox and the hedgehog. We need to be the fire department and MABUS. So for those of you who don't know, MABUS is the mutual alarm box alarm system. And it's sort of a coordinating entity for fire departments throughout the state. I don't believe that includes the city of Chicago. But MABUS is who makes sure that all the individual fire departments are talking to each other and covering for one another when there is that 5-alarm fire. So I think public health certainly needs to be in that role. But at the same time, we need to be equipped to investigate and respond to outbreaks when they happen. We need to be able to provide workplace inspections and restaurant inspections and so forth as well. And as to that coordinating role, I think it's like pretty much well understood at this point that we need to be at as many tables as possible if we're to truly make an impact on how the social determinants are distributed.
Thank you. Allison?
Yes. So, I mean, I work in local public health for a reason. Like, despite, where I started, all the administrative stuff, et cetera, I've worked in academic medicine. I've been at the CDC. I was at the state level. For me, local public health is the space where we have the ability to use the authority that is granted in a way that brings other voices in, but I wouldn't be working in this field if I didn't think that there was a major need for public health to have, some of the powers and the regulatory capacity that it does. We've learned a lot about what public health does sort of as a society over these last couple of years, but I would venture to say most people in Chicago don't know that the #1 job at CDPH is a sanitarian, a restaurant inspector, right? People expect that when they go to a hospital, they won't be catching an infection, right? That is the Illinois Department of the regulatory arm of this, right? Our environmental inspectors, do we want to actually be able to hold polluters accountable and make sure we can come after them? Our lead poisoning inspectors, like there's this regulatory piece that people don't think about that much, but they don't want it to go away. They want to trust that their water, all of these things that we've done to sort of actually create the policy systems environments are in place. It's just that goes unnoticed a lot of the time, right? When public health is going well, nobody notices us. And so it's only when these things, and I forget who said it, but maybe it was Karen, just this thing of like the individual, or it was Rachel, the individual right, sort of people feel like we're infringing on that individual right. Well, sometimes we have to, and we don't do that lightly, but I don't really think, and I would argue that this last year and a half has shown that we should have some worry about letting some of the politicians make some of those decisions. And if you don't have the ability to have a somewhat independent public health authority that is able to make those decisions that help protect everybody's health, yes, protect your privacy, yes, protect your individual rights until you're giving tuberculosis to the person next door, right? I believe very strongly, and I'm really worried that there are places around the country that we are seeing this erode legally. And it's going to be a problem I worry about. So, but it's an important conversation to be having, and the point around clarifying what that role is and how we use it and how we don't, I do think will be important.
Thank you. I want to, before I turn this back over to Wesley, I want to thank all of you for an interesting and invigorating conversation. Let me just say at the end, I won't live to see this, but hopefully some of you will. We don't have a national public health system in the United States because of our constitutional structure. We have 50 states and territories. They all operate on their own. And I just don't think we can face international problems like coronavirus or climate change and other issues with our old-fashioned 1700 fragmented health system. So I think we have some real structural challenges that we're going to have to come to grips with within the context of our American political system. But having said that, let me now turn it over to my colleague, Wesley Epplin, to have us go out of this. Go ahead, Wesley.
Great. Thank you so much, Dr. Murray. And thank you to all of our panelists for your insights, for your sharing your experiences with us. I know I learned a lot. I also want to thank our audience for joining us today. Again, the recording will be available and we'll send it out to you following the event. I also want to thank my colleagues for helping develop this series: Margie Shafts, Miriam Siddiqui, Shannon Sweetnam, Claire Thatcher, our members of our board who also helped with ideation and developing the forum series. So truly a team effort here at Health and Medicine. And on behalf of Health and Medicine, thanks so much and have a great evening.